to May to present the first speaker. Most welcome, everybody.
Welcome everybody to our third webinar. This time it's about total anomalous pulmonary venous drainage. And our first speaker will be Professor ICSHD, Professor of Cardiology at Ain Shams University. He's the ex-director of the cath lab, and he's an experienced congenital and structural heart interventionist. And is going to talk about total anomalous pulmonary venous drainage, imaging hemodynamics.
Thank you, Dr. Mai. Thank you, all the distinguished speakers and panelists. It's my pleasure to share in this webinar and to share in all PACHDA activities. I am just going to try to stick to time, I hope. I'm going to talk about the total anomalous pulmonary venous drainage and the core triatriatum sinister. So first, I will be talking about the total anomalous pulmonary venous drainage, which usually consists of an abnormality of blood flow in which the pulmonary veins drain into the systemic veins or the right atrium with or without obstruction. Usually an atrial septal defect is essential part of this abnormality, and because all pulmonary venous return connect to the systemic venous system, right atrial and right ventricular enlargement is mandatory. Usually the total anomalous venous drainage occur alone in 2/3 of the patient and as part of a group of defects in the remaining third. The most common classification of this type of anomaly is the Darling classification, which divides the total anomalous venous return into 4 types. Type 1, which is a supracardiac connection. Type 2, which is the cardiac connection either directly to the right atrium or through the coronary sinus. Type 3, which is the infradiaphragmatic connection, and the mixed type or type 4. Pulmonary venous obstruction may occur in all of these types, and in all types, the obstruction may occur because of the restrictive atrial septal defect or the small left atrial size. However, there is some peculiar sites of obstruction for each of these types. For type 1, the obstruction can occur at the origin of the ascending vertical vein or at its attachment to the innominate vein, and commonly can also occur as it crosses between the left pulmonary artery and the left bronchus. Type 2, seldom obstruction develops, but it can occur at the junction of the common vein to the coronary sinus, and the infradiaphragmatic type can travel through the diaphragm where it shows some obstruction, and also obstruction can occur at the junction with the portal venous system. The hemodynamics usually depends on either one of 2 pathways. The total anomalous pulmonary venous drainage can cause right-sided volume overload, which in turn leads to an increase in the pulmonary blood flow, and finally leads to pulmonary hypertension, or can lead to pressure overload in obstructed cases with systemic and pulmonary venous congestion, and finally also pulmonary hypertension. And in all these types, the left atrium and left ventricle are underfilled with decrease in the cardiac output. The anomalous venous connection without pulmonary obstruction, usually the venous site of the anomalous connection is identified by highly saturated blood. The oxygen saturation in the right atrium is usually in the range between 80 and 95%, and also the saturation in the right atrium, right ventricle, pulmonary artery, and the left side and systemic arteries are nearly identical. The pressure in the right ventricle and pulmonary artery can be slightly elevated to equal or higher than the systemic pressure, depending on the presence of obstruction. The interpretation, however, of atrial pressures and the adequacy of inter-atrial communication can be difficult, and the presence of equal pressures in 2 atria usually denotes no obstruction. However, a right atrial pressure more than 2 mm mercury can reflect obstruction across the inter-atrial communication. What about the diagnosis for the total anomalous venous drainage? Diagnosis may be difficult, especially in ill newborns on ventilation, because the views of the left atrial septum and the left atrium can be difficult. But the addition of color Doppler imaging greatly aids in the diagnosis. But before we go to the diagnosis using echocardiogram, I would like to point out to a very common but misused or disused modality, which is the chest X-ray. In patients with total anomalous venous drainage and pulmonary obstruction, there is a peculiar diffuse reticular pattern, as in the chest X-ray seen here in a case of total anomalous with venous obstruction. While in cases with no obstruction, usually the pulmonary vascular markings are increased in size in the hilar and the mid-zone vessels. And in total anomalous venous connection of the supracardiac type, the classic snowman appearance or the figure of 8 appearance of the vertical vein is also very pathognomonic. However, the echo remains the gold standard for diagnosis of this condition. The goals of any echocardiogram should be to size the pulmonary veins. The connection of all the 4 pulmonary veins to the confluence should be visualized. Also, the size of the pulmonary venous confluence and its relation to the left atrium should be visualized. The course of the pulmonary venous channel and whether there is obstruction or not, and to evaluate the interatrial communication and any additional anomalies. Here is a classic picture of a markedly dilated right-sided structure with rather very small or smallish left atrial chamber and left ventricle, which is very pathognomonic of any type of the total anomalous pulmonary venous connection. The apical and subcostal 4-chamber view usually best identifies the individual pulmonary veins. And then using multiple views, the common pulmonary vein can usually be tracked to its point of entry to the systemic venous system. Here in this slide, we can see the confluence of the pulmonary veins ascending into the vertical vein, and then to the innominate vein and crossing in the opposite direction to the SVC. So we need to track the venous connection from its origin from the pulmonary venous confluence until it joins the innominate vein and then back into the right SVC to obtain a complete picture of the circulation of the total anomalous venous drainage. And here is another very pathognomonic view. This is a subcostal view where we can see a stretched PFO or a small interatrial communication, and we can see clearly the left atrium, a very small left atrial chamber, and the pulmonary venous confluence is located here above the left atrium. And usually the color flow would add a lot of information to this picture and will confirm the diagnosis. Here is the color flow. We can see clearly that the stretched PFO is shunting clearly right to left, and the venous confluence is seen with no communication to the left atrium, and there is a very high flow jet coming from the innominate vein into the dilated right SVC. This is a very pathognomonic picture of a supracardiac total anomalous pulmonary venous connection. Also, we need to properly identify any possible sites of obstruction. Here is a turbulent flow denoting the obstruction of the vertical vein as it crosses between the left pulmonary artery and the bronchus. And this would be confirmed by Doppler signal, confirming the presence of a significant gradient across this site of the turbulence flow. Usually an increase in the flow velocity with the turbulent flow and loss of phasic variation is characteristic of obstructed pulmonary venous channel. Here is a zoom-in view of a similar patient where there is a very characteristic turbulent flow of the vertical vein as it crosses between the left pulmonary artery and the bronchus, causing a characteristic obstruction at this site of the type 1 total anomalous pulmonary venous connection. What about the infracardiac total anomalies? Perhaps might be even more challenging to diagnose. Here we can see the connecting vein or the vertical vein, but running actually downward across the diaphragm into the liver and joining the portal circulation. And at the site of turbulence flow here is noted at the insertion of the vertical vein into the portal venous system or the ductus venosus system, denoting a pulmonary venous obstruction at this site. This is another case of total anomalous pulmonary venous connection where the venous confluence is actually joining the inferior vena cava immediately before its insertion to the right atrium. And this is the total anomalous pulmonary venous connection of a cardiac type, where the venous confluence on both sides is joining the coronary sinus, and then the coronary sinus opens into the right atrium. This is another patient showing the characteristic whale tail appearance of the pulmonary venous connection, where the two pulmonary venous confluence are joining the coronary sinus in a picture similar to the whale tail. And then the coronary sinus flow joins into the right atrium. In cases where the anatomy is a little bit lacking, or if we are not sure if the pulmonary veins are draining completely into a single venous confluence, or if there is a suspected obstruction or associated anomalies, a multi-slice CT can be helpful in this diagnosis. Here is the multi-slice CT with volume rendering to establish the complete circuit of the pulmonary venous drainage into confluence, and then joining the vertical vein to the innominate vein, and finally to the dilated SVC, a similar picture to what we have just seen by echo. And these are other examples of volume rendering multi-slice CT. Here we can see the detailed anatomy of the venous drainage joining into the confluence, and then passing through a vertical vein, and then the vertical vein joining the innominate vein to the right SVC. A very detailed picture actually of all the extracardiac vascular structures here, which is a very peculiar advantage of multi-slice CT in this type of abnormalities. And here is the infradiaphragmatic type, where the pulmonary veins are joining the vertical vein, which is crossing downward across the diaphragm to the venous confluence to the portal circulation. Cardiac MRI has a very limited role, actually, because the multi-slice CT is more readily available and usually provides us with all the anatomical details required. However, the cardiac MRI has a peculiar benefit of identifying the flow across any vascular structure. And the angiogram are now rarely needed because of the almost all the detailed anatomy are obtained by echo and multi-slice CT, but in selected cases, pulmonary vein injection or pulmonary artery injection may precisely reveal the vessel anatomy, and in selected cases, even the vertical vein itself can be directly accessed, like in this case where the catheter has crossed from the superior vena cava to the innominate and back into the vertical vein, as we can see in this angiogram. For the interest of time, I will just skip this disadvantage of all the imaging modalities we just described, and we will go to the final phase of our talk, where we are going to talk about the cord triatriatum sinistrum. This is a rare condition which refers to the failure of incorporation of the normal pulmonary veins into the left atrium, and it accounts for up to 0.1% of the congenital heart disease. There is separation of the left atrium into two chambers separated by the membrane, the posterior chamber, which usually drains the pulmonary veins, and the anterior chamber, which is the true left atrium, connecting the remaining portion of the left atrium to the left ventricle across the mitral valve. The membrane that divides the atrium into two parts may vary significantly in size and shape. It may appear like a diaphragm, or funnel-shaped, or band-like, or entirely even intact or imperfect. In addition, the accessory chamber itself may communicate with the right atrium through an anomalous channel. So we have a large variety of classification actually for this type of anomaly. We can have an accessory atrial chamber which receives all the pulmonary veins and communicate to the left atrium with no other connection, which is the classic form of a cord triatriatum. If we have other anomalous connection, we may have connection to the right atrium directly or through a total anomalous venous connection. We may also have accessory atrial chamber receiving the pulmonary veins but does not communicate to the left atrium, and can communicate also to the right atrium or to the anomalous pulmonary venous connection. And we may have a subtotal cord triatriatum with the accessory chamber receiving part of the pulmonary veins, and the remaining veins either drain normally or anomalously. And we may have an accessory chamber receiving part of the pulmonary veins and connecting to the right atrium. So I can see a very large variation of anatomy here, and the presence of a membrane in the left atrium needs a very careful attention to know where the pulmonary veins are exactly draining and whether this drainage is connected to the remaining left atrium proper, or connecting anomalously, or connecting to the right atrium, because all these are valid possibilities concerning this pathology. If no alternative pathway for the accessory chamber with stenotic opening to the interatrial membrane, this will result in elevated pressure across the accessory chamber and will be transmitted to the pulmonary vein. A physiology similar to pulmonary venous obstruction in severe cases will result in secondary pulmonary hypertension, while a mild gradient across the membrane may not reflect the high resistance across this circuit, especially in the presence of a decompression atrial communication. Here is a parasternal long axis where we can clearly see the membrane. And if we put color here, we can see the high turbulence flow communicating the accessory chamber to the true left atrium. And this high turbulence denotes a very obstructed membrane, and one can expect the presence of a similar physiology as pulmonary venous obstruction or mitral stenosis in these cases. And here is the four-chamber view. Here again, the membrane and the presence of a high turbulent jet denotes the presence of obstruction or narrow opening of this membrane, which is hemodynamically significant obstruction. Here is another case where the membrane has a very eccentric opening at its junction with the pulmonary vein ridge and left atrial appendage junction. In cases where the suspected anomalous origin of the or drainage of the pulmonary veins or associated extravascular anomalies are suspected, the multi-slice CT can be helpful. And here the multi-slice CT can properly visualize this filling defect here, depicting the membrane and the pulmonary venous connections. And here we can clearly see the pulmonary veins draining directly into this accessory chamber, and the left atrium proper receiving the left atrial appendage and the membrane almost separating these two chambers. Thank you very much.
Thank you, Dr. Ala, for this comprehensive talk. Just some housekeeping questions. Please write your Q&As in the Q&A box, and we'll have all the Q&As after finishing the webinar. Terminate. Can you hear me?
Yes, I'm hearing you. Our next speaker is Dr. Zahir Ahmed. Dr. Zahir is a consultant pediatric cardiologist at King Faisal Specialist Hospital in Jeddah, Kingdom of Saudi Arabia. Dr. Zahir, today he will present about partial pulmonary veins return and Scimitar syndrome. Most welcome, Dr. Zahir. Mic is yours.
Okay, thank you very much. Can you guys hear me?
Yes.
Okay, thank you. So I would like to start with my topic for today, which is partial anomalous pulmonary venous return and Scimitar syndrome. I would generally go like a brief overview of the nomenclature of partial anomalous pulmonary venous return, but would like to spend more time onto Scimitar syndrome. So by definition, partial anomalous pulmonary venous return is when less than 4 pulmonary veins drain directly either into a systemic vein or into the right atrium. It's an uncommon anomaly in isolation, and most of the time it's the right lung which is involved. There are two key concepts in partial anomalous pulmonary venous return. One is partial anomalous pulmonary venous drainage, where you have pulmonary veins in their normal place in the left atrium, but because there is a malposition of the septum primum, that's why the oxygenated and deoxygenated blood gets mixed in the right side and leads to the volume overloading of the right-sided chambers. The other one is sinus venosus defects, where again the pulmonary veins are supposed to be in the normal position, but there's unroofing, and that's why you could have volume loading of the right side of the heart. So these are partial anomalous pulmonary venous drainage with normal connections. But if we talk about a true anomalous pulmonary venous connection, that means that anomalous pulmonary veins directly connect with a systemic vein or rarely to the right atrium. The important examples are if you have left-sided pulmonary veins, usually they connect to the vertical vein and then through the innominate vein connect to the right-sided chambers. On the right side, the most important one is when you have the right-sided pulmonary veins, which drains into the inferior vena cava, which we all know as Scimitar syndrome, and I will talk about that in much detail. Apart from that, single isolated pulmonary veins can drain into any of the right-sided veins. So usually, in terms of presentation, it could be like an asymptomatic incidental finding, or symptoms might be due to associated lesions. And generally, the implications are right ventricular or volume load and pulmonary hypertension in later life. For example, in this patient, he presented in this third decade of life with a shortening of, breathing, shortness of breath, and then was found to have anomalous pulmonary veins of left-sided anomalous pulmonary veins, which were draining to the right side. You could see in this slide. So in terms of management, it depends on the degree of left to right shunt. And usually if it's an isolation, single pulmonary vein, then probably you can leave them alone. And if you can always do an MRI to determine QPQS, and if it's more than 1.5:1, then they qualify as a surgical candidate. Now, going to the topic of Scimitar syndrome. So the important components of Scimitar syndrome there's anomalous pulmonary venous drainage, usually from the right-sided lung. And you could see in this angiogram that there's a Scimitar vein which drains the lung below the diaphragm to the IVC. And that's like the most common presentation. Rarely, it could be from the left lung. And sometimes, rather than draining into the IVC, the Scimitar vein can drain into the right atrium directly. Apart from that, because there's hypoplasia of the right lung and right pulmonary artery, that's why there's dextroposition of the heart. You could see in this image that the heart is dextropositioned to the right side. And another important component of this disease spectrum is an abnormal arterial supply to the right lung, primarily to the right lower lobe, which we call as aortopulmonary collateral. And that probably has the most important implications in terms of pulmonary hypertension and their further management. Other associated lesions could be an atrial septal defect, patent ductus arteriosus, or ventricular septal defect. And apart from that, it could be any other complex congenital heart defects, for example, tetralogy of Fallot, or even single ventricle. And in terms of non-cardiac anomalies, they can have ipsilateral diaphragmatic anomalies and a horseshoe lung. Like in this image, you can see a right lung, which is also connecting to the left side as well. So in terms of subtypes, we can divide them classically into infantile and isolated adult. In infantile, in terms of their presentations, they could be early scimitars, and usually they have associated congenital heart defects, or they could be like isolated, which we label them as stable scimitars. Clinical presentation in infantile type, the most important presentation is in heart failure or recurrent chest infections. Usually, if they have associated congenital heart defects, then they might be presenting in a neonatal period, unable to wean from ventilator, persistent right lung collapse, or those kind of presentations. We should always think about Scimitar syndrome. And really, they can also present with cyanosis because of significant pulmonary hypertension leading to right to left shunt across the intra-atrial communication. I just wanted to spend some time on this slide because pulmonary hypertension is the major contributor in terms of bad prognosis in Scimitar syndrome, and we need to look for the possible causes of pulmonary hypertension. So the most important cause is aortopulmonary collateral, which are present in about 60 to 70% of patients with Scimitar syndrome. Apart from that, we also need to exclude cardiac shunts like a patent ductus arteriosus or a hemodynamically significant VSD. Then coming down, stenosis of the scimitar or other pulmonary veins can also lead to pulmonary hypertension. And always we need to look for the left-sided pulmonary veins as well, because they might be contributing to pulmonary hypertension. Last but not the least, sometimes it could be pulmonary hyperplasia, which could result in vasculopathy in the right lung or increased pulmonary vascular resistance in the left lung. So whenever we are dealing with scimitar, we need to look for these contributors for the pulmonary hypertension for a better treatment options. In adult type, usually they have milder symptoms. They could be totally asymptomatic. And sometimes if you see an unexplained RV dilatation on echo, always try to exclude scimitar syndrome. And rarely they can present with some rhythm problems due to chronic volume overload. In terms of diagnostic workup, we can always start with something very basic like a chest X-ray, and it has been classically described as a Turkish sword, where you could see anomalous scimitar vein which drains down into the IVC. But honestly speaking, these signs are very subtle in early infantile period, and usually these kind of signs you pick up more in the adult type of presentation. So our bread and butter always is an echocardiogram. Echocardiogram you can see right heart dilatation. You could see a scimitar vein, as you could see in this patient. It's entering into the IVC. Always exclude associated cardiac defects, and always look for left-sided pulmonary vein stenosis, as I described earlier. So this is one of our patients who presented at 2 months of life. He was ventilated. He presented, and you could see there is significant right-sided dilatation and volume loading. And he had high TR gradient, suggesting very high right-sided pressures. You could also see an hyperplasia of the right pulmonary artery. And in short view, you could see we can see left-sided pulmonary veins draining normally, but we could not see the right-sided pulmonary veins. This patient had a significant aortopulmonary collateral, which was occluded, and this is an echocardiogram for 6 months down the line, and you could see probably there is less dilatation of the right side of the heart with a mild TR, and there's significant regression of the pulmonary hypertension. So again, signifying that the importance of aortopulmonary collateral, that they need to be occluded. Cardiac CT MRI can give you more information about in some cases, especially if you're suspecting stenosis of this scimitar vein. It can also show you aortopulmonary collaterals. In adult patients, when you want to decide about whether they are surgical candidates or no, it can help you in QPQS determination. And especially in postoperative patients, it's important to exclude any venous pathway obstructions. Cardiac catheterization, we should not use it as a routine diagnostic tool. For me, the most important role of cardiac catheterization is therapeutic, that you can occlude aortopulmonary collaterals and PDA closure even in the same sitting. And sometimes, as pulmonary venous obstruction could be a problem postoperatively, so you can deal with that in the interventional way. So here's an example. You could see a large aortopulmonary collateral, which is draining, which is in the left lower zone, and then it was occluded with a coil. Here is an example of a venous obstruction. Post-operatively, this patient has rerouting of the veins, and then there was significant stenosis. And it was stented, and then you could see a good flow post-stenting. So in terms of management, general principles are medical management of heart failure and interventional. Again, I would like to emphasize that always close the aortopulmonary collaterals, and if there's a significant PDA, we should also close it as early as possible in early infantile age. Surgery, there are certain indications. In infantile form, if you are not able to control symptoms, or if there is presence of significant pulmonary hypertension despite of closing aortopulmonary collaterals and other significant shunts, then we have to think about different surgical options. In adult form, Usually, you need to think it as an ASD physiology, and if QPQS is more than 1.5, then we should think about the surgical options in terms of rerouting the scimitar. I will not go into details of surgical options, but these are the different options available that you can redirect the venous drainage to left atrium, repair of intracardiac lesions, and in resistant patient, especially who are struggling with severe pulmonary hypertension, you may not left with any other option apart from pneumonectomy or lobectomy. Last few slides about the outcome and prognosis. This is a paper from 2007, which talks about outcome after surgical treatment of children with partial anomalous pulmonary venous connection. It includes both scimitar and non-scimitar veins. And you could see that non-scimitar, there is an excellent outcome, but when you talk about the scimitar veins, there were significant patients who ended up with trouble, they are at much higher risk of getting pulmonary venous obstruction after repair. Another paper which talks about outcome predictors and implications for management of scimitar syndrome. In this paper, they looked at 80 patients in 35 years. Out of 36 patients underwent scimitar vein surgery. And here, the important point is that if you are significantly pulmonary hypertension, if the PA pressures are more than half systemic, your survival declines. And that's why patients with severe pulmonary arterial hypertension are at much higher risk. So the conclusion of their paper was that there was high rate of postoperative pulmonary vein obstruction, especially in infancy, and pulmonary hypertension and left pulmonary vein stenosis are independent risk factors for death. And they strongly suggested that the closure of aortopulmonary collaterals should be done to avoid the need for scimitar vein surgery. This is an excellent paper which was published in 2017. This is an European registry where it's a multi-center study which looked at almost 500 patients with scimitar syndrome, and they divided them into two groups: surgically treated patients and clinically monitored patients. And you could see that the hospital mortality was there was a 6% mortality in surgically treated patients, and there was also almost similar mortality in clinically monitored patients. If we talk about survival probability according to pulmonary hypertension, again, it comes with the same observation that if you have pulmonary arterial hypertension, your survival rate goes down. When in an isolated form, it may not be that significant, but in patients with associated defects, that is a very significant risk factor. Then they also looked at the patients in terms of clinically monitored patient and surgically treated patients, and their conclusion was that probably patients who were just clinically monitored in long term, they had relatively poorer prognosis as compared to surgically treated patients. Maybe they were left too much late for their repairs. Also, outcome of patient with postoperative scimitar vein stenosis. There was a significant number of patients who developed, about 25% of patients who developed this complication. In our local experience, we had 24 patients, out of them 5 had surgery, 3 had rerouting and 2 had pneumonectomy, and there were 3 deaths. Both patients who had pneumonectomy died, and that again tells you that both these patients were bad prognostic factors because severe pulmonary hypertension, and they could not survive. Out of the rerouting patient, 1 patient died. He was an infant, and other two survived, although one of them had pulmonary vein stenosis. So I would just like to concentrate on this slide a little bit more. That's how I think we should be dealing with these patients. Any suspected patient of scimitar, we should do a 2D echo and CT to confirm the diagnosis. CT can tell us if there are any significant aortopulmonary collaterals or not. Then if they're isolated scimitars and no collaterals, we can just observe them, and later on in their life, if their QPQS is more than 1.5, you can always think about surgery for rerouting. In those patients who have aortopulmonary collaterals, PDA, we can occlude them. And if there's significant regression of pulmonary hypertension, again, they can be treated like an ASD. But if there's progressive pulmonary hypertension, then we should look for other causes like obstruction, etc. And we have to think about other options even lobectomy or pneumonectomy. Those patients who had associated significant congenital heart defects, obviously they need surgery for their defects. And again, rerouting is an option. It again depends on the surgeon's expertise. It could be done in the same setting, or it can be left for later time, because all the studies have proven that if this rerouting surgery is done later in life, it has a better outcome. So in summary, I think I would like to conclude that if you have an isolated stable scimitar, it's better to manage them conservatively. We have to be aggressive about closure of aortopulmonary collaterals, and we have to treat pulmonary hypertension early and in aggressive way. Thank you very much.
Thank you, Dr. Zahir. Very elegant presentation, actually, and full of information. Thank you very much. We will have some discussion later on. Please stay on.
Sure.
Okay, so I will leave the mic to Dr. Khalid Najafi to present the next speaker. Thank you very much.
Assalamu alaikum. So it's a pleasure introducing Dr. Ashraf Al-Madani, a professor of cardiothoracic surgery, Faculty of Medicine in Ain Shams University, consultant pediatric cardiac surgery in more than one institution in the Ain Shams University and in Saudi German Hospital. It's yours, Dr. Ashraf.
Ashraf,
Yes.
you please start your presentation.
Just I'm sharing this the presentation.
Would you go to full screen?
Yes. On screen.
It's not yet full screen, Dr. Ashraf.
Yes, I'm going to. I want to go. I don't know why.
Just click on the full screen.
I'm going to. I don't know why. The problem.
Down in the bottom, Dr. Ashraf. Full screen icon.
Not sure what this is.
Maybe you need to
Doctor,
share
can
the
you go
screen
full
again.
screen?
Yes.
The screen is.
تحت على اليمين يا دكتور.
أنا بشوف أهو والله.
دكتور اشرف مساء الخير. حضرتك محتاج الاول تكبر الويندو بتاع الباوربوينت من فوق خالص يمين جنب الاكس الموجوده دي في شباك كبير. ايوه ده كده نكبره بعد اذنك. دوس عليه. تمام كده. تحت خالص يمين هتلاقي حضرتك العلامه بتاعت الفول سكرين او F5. تمام كده حضرتك. You can proceed. Thank you.
Okay. Now you can see the presentation perfectly, huh?
Yes, perfectly. Please proceed.
Okay. Sorry for this disturbance. Good evening, everybody. Thank you very much for this kind invitation to participate in this webinar about the anomalous pulmonary veins, about the surgical repair of this such complex topic. Actually, it's a very complex topic is the anomalous pulmonary vein, because it includes many forms, including the anomalous connections, either total or partial, anomalous drainage, either total or partial, either stenotic connections, stenosis of one of the or more of pulmonary veins, or chordoatrium, or this abnormal number of pulmonary veins. However, this number 4 usually does not need any surgical intervention. To go through this important topic, we will go through the most important points and the surgical challenges we have in this anomalous pulmonary veins. First of all is the total anomalous pulmonary venous connection. This rare and heterogeneous anomaly characterized by failure of the absorption of this pulmonary venous confluence into the dorsal portion of the left atrium in combination with persistence of splanchnic connection to the systemic venous system. It's a cardiac malformation which there is no direct connection between the pulmonary veins and the left atrium. Rarely, all the pulmonary veins connect to the right atrium or one of its tributaries. As Dr. Ala said in his presentation, actually there are 4 forms, and the most suitable surgical classification is the Darning's classification into type 1 supracardiac, type 2 cardiac, type 3 infracardiac, and type 4 is the mixed form. This is one example of the supracardiac form. And this is another type 2 is the connection to the coronary sinus. And this is the cardiac form type 2. Type 3 is the connection to the portal vein or the IVC. And the mixed one is the type 4 morphology of the total anomalous pulmonary venous connection. What we have is as a challenge in the surgery is to know this total anomalous is obstructed or non-obstructed, because this is either it's an emergency situation or just an elective situation. To know this one is by, as Dr. Ala also said in his presentation, the main diagnostic tool is the echocardiography, and can reveal this item of diagnosis is to know the basic morphology and also the obstruction, whether obstructed or not. But if we have some lacking information, we will go through CT. The diagnosis of preoperative pulmonary venous obstruction by oxygen saturation and echocardiographic data is usually enough. The morphologic features of these obstructions, either intrinsic stenosis into the pulmonary ostial stenosis or pulmonary venous hypoplasia or both, or extrinsic stenosis into obstruction with anomalous connecting vein or its connection to the systemic circulation, or restrictive atrial septal defect. So we have the goal to know of surgery to know is to create an unobstructed route of blood from those pulmonary veins into the left atrium. The various approaches have been adopted for surgery for this goal. The total anomalous pulmonary venous connection type 1 has many approaches, either posterior approach, right atrial approach, superior approach, lateral approach. All of them, we have the same goal, is to make the direction of blood unobstructed into the left atrium. Indications for surgery is the diagnosis. Once the diagnosis is made, we should go to surgical repair. However, the obstructed total anomalous is maybe now the non-pediatric cardiac surgery emergency, because I think it's we cannot go for medical management, for cath management, for any management other than the surgery. Surgical intervention during the first few days or weeks of life, usually we go through this. The posterior approach is to go through the left atrium, connecting to the left atrium to the pulmonary venous confluence posteriorly into a very wide anastomosis, so we can go without an obstruction. The right atrial approach is to go through the right atrium, the septum, and the posterior LA, and then connecting the pulmonary venous confluence posteriorly also to the left atrium, very, very wide anastomosis. All of these approaches are adopted to increase the route of the blood without any obstruction to the left atrium. The superior approach is also the confluence to the left atrium superiorly between the aorta and the superior vena cava. The lateral approach is to connect the vertical vein, the ascending vertical vein, into the left atrial appendage. Surgery for type 2 cardiac type is the only unroofing of the coronary sinus into the ASD with the wide closure of the ASD by a pericardial patch, so direction or rerouting of the pulmonary veins into the left atrium. Surgery for the type 3 is a more complex one. Usually also the infracardiac is obstructed type of of anomalous connection, right atriotomy performed and incision extended across the interatrial septum into the back of the left atrium, then also connection of like this with the connection of the pulmonary venous confluence into the back of the left atrium. Here we can see through the ASD, and then closure of the whole ASD by a white patch, also to enlarge the left atrium and to encourage blood to the left atrium through an unobstructed route. The surgical outcome of this, all these maneuvers or approaches, the surgical mortality has decreased with the advances in the cardiopulmonary bypass and neonatal ICU management from 50% in 70s to 20% in recent studies. Most of death is the heart failure and the hypertensive pulmonary artery crisis. The poor postoperative survival has been associated with the neonatal surgical repair, preoperative pulmonary venous obstruction, mixed anatomic variation, single ventricle, and heterotaxia. Postoperative complications, the early postoperative complications includes pulmonary edema, pulmonary hypertensive crisis, phrenic nerve damage, or rhythm disorders because of the suturing through the atrial walls. And the rate postoperative complications includes pulmonary venous obstruction, anastomotic stricture, and pulmonary venous stenosis. The operation usually was due to pulmonary vein stenosis due to anastomotic strictures, and this is about 11% for an isolated total anomalous pulmonary venous connection. The partial anomalous pulmonary venous connection, usually we found it as left pulmonary veins draining into the left innominate vein. And this is the commonest variety, but we have other varieties like right pulmonary veins to the SVC or to the IVC, or the left pulmonary veins to the IVC. All of them, if we have a significant hemodynamic effect, we go for surgery. Otherwise, we keep it the same. The total anomalous and partial anomalous pulmonary venous drainage is different from the connections. As we said, the connection is due to failure of absorption of the pulmonary venous confluence into the dorsal portion of the left atrium. However, the drainage is due to abnormality of the septum of the atrium. The sinus venosus defect comes when there is deficiency of the common wall between the right SVC and the right upper pulmonary vein, or the wall between the right atrium and the right upper and lower pulmonary veins. So the drainage of the pulmonary veins is normally connected, however, drained into the right atrium rather than left atrium. In the malposition of the septum primum displaced towards the anatomic left atrium with incorporation of the half or all pulmonary veins into the right atrium. So also it's normally connected, however, it's draining falsely into the right atrium rather than left atrium. Also, all of these drainages, we go for rerouting of the pulmonary veins into the left atrium through buffling by pericardial patch from inside the heart. Cortical atrium, as Dr. Ala said, that's the connection between the left atrium and comes when the connection between the left atrium and the common pulmonary vein confluence becomes stenotic. So the common pulmonary vein stenosis ends into dilatation of this common pulmonary vein and comes two chambers. One is draining the pulmonary veins and the other is the proper left atrium. It comes into cortical atrium, either on the left side sinister or the right side comes dexter. It's characterized by presence of fibromuscular membrane to divide the left atrium into proximal accessory chamber, receives the pulmonary veins, and distal chamber, as we said, is the left atrial proper, goes to the mitral. And we have three anatomic variations: diaphragmatic or hourglass or tubular. All of them we go for surgical management by resection of this fibromuscular membrane. Thank you very much.
Thank you, Dr. Ashraf. Most very elegant presentation. Actually, it's a big topic and difficult to summarize in 15 minutes. Thank you very much again. We will have some discussion at the end. It is my pleasure to present the next speaker, who is Karim Galal. Karim is a medical student in his final year at Paracelsus Medical School in Germany. Karim today, he will talk about physiology of learning and practical application in medicine. Most welcome, Karim.
Hi there, I hope everybody sees my slides. Thank you very much for having me at this conference. I hope that everybody can profit from my presentation. I realize that many people attending are consultants or professors in their own fields and of course have learned efficient strategies of memorization and learning. For those attendees, of course, this will be more of a all-around presentation about how learning works and what sort of options there are in modern, using modern technology. For younger attendees, it might be an interesting insight into how I tackled the massive amount of information that we've all had to tackle in medical school. I'm gonna talk about first how I got to this topic. Then I'm gonna talk a little bit about what we know about memory itself and learning, what we know about learning, and given what we know about those things, how can we apply that? Basically, I'm coming from the point of view of somebody coming into medical school in 2017 without much medical background. The program that I entered is an Austrian program where we follow the standard European 6-year program, but it's been compressed into 5 years. We have mandatory lectures, and I've put one of my weeks of studies, this is from last year, where you can basically see I have classes all day where I have mandatory lectures. At the same time, I have exams every 2 weeks. And coming new into this sort of field is something where I'm presented with a huge amount of information, and I have to ask myself, how do I learn this quickly and efficiently given the time that I have? I eventually ended up Googling how medical students do this in other countries, and everybody sort of pointed me into the same direction, which is a program that at the end of this presentation I'll introduce, and basically is a digital form of flashcards, but that uses learning methods and learning physiology to have a very efficient system for memorizing and learning quickly. First, to memory, how does memory work? There's 3 types of memory. Just using me presenting right now, there's a memory that you're using to listen to my presentation and be able to connect it to the slides before it and connect it to an overall idea. There's also the memory that you might have in 1 week thinking about this presentation, hopefully, and remembering some aspects of it. Now, if you were to repeat and revise what I'm talking about today, then it would eventually be stored in your long-term memory. And this is nothing new or novel to any of us. We're aware that if we repeat and revise information, eventually that becomes information that we know. There is information that we can recall and can remember, but there's also information that we know that we know. And it should be no surprise that if we look at the brain and if we look at neurophysiology, that many of the pathways in the brain mimic exactly what this repetition represents, which is the strengthening of neurons, the repetition of information, and how this is reflected in the brain is, this is in fact a cycle in the brain where learning is taking place, apparently from what we've observed in the brain. But the cycle of walking or the cycle of learning new actions or movements is not very dissimilar to this. You have a series of neurons, and when the connections between those neurons are strengthened and the interconnections between parts of the brain are connected, by repeating and by using those neurons again and again, we form longer term memories. At the same time, we do forget, and everybody forgets, everybody is aware of forgetting, and everybody's been aware of forgetting for as long as humans have been around. There have eventually been people that looked into what exactly is happening and how do we forget. And this started in the late 1800s, where a professor called Ebbinghauser looked into theories of forgetting. He started observing in himself and testing himself by learning series of random numbers and noticing that he would forget those numbers at a steady pace, but by revising those numbers in spaced intervals, he was able to recall them for a longer and longer time. And so what he would do is memorize a series of random numbers and repeat them the day after and try to memorize them again or see how much he could recall. And then if he was able to recall any series of numbers, he would repeat that information after 3 days. And then he would repeat that information after 9 days, the information that he had retained at that point, and so on and so on. And by doing this, he was able to observe that while he still had a sort of forgetting curve, he was able to maintain the information over a longer series of time. Here is a picture of him, a classic late 1800s sort of professor. What these quotes here are saying, also from other professors that have also looked into it a bit later on, is essentially what I'm saying. You have to both repeat information, but you have to repeat that information over a series of increasing intervals of time in order to implant it properly in your memory. So the point is now, okay, now we know a few things about how we learn, and we can observe in ourselves that this is how learning takes place and how memories are formed. But the point is that if we know this about ourselves, and if we know how learning processes work, we can start to make learning and memorizing a choice rather than something that happens to us. Now, obviously, everybody that is attending today has found strategies for themselves to learn. The issue is, not issue, but the goal or challenge is to learn efficiently and to learn in a way that is effortless and to make it a pleasure to learn or make it almost a game to learn. And if we can achieve that, then we can come a very long way with learning, because we essentially have to only decide that we want to learn a topic and then start doing it. Once the action is automated and once the action is based on physiology and actions that are known to form memories quickly and efficiently. This idea and these ideas that I've just discussed were in fact made into strategies of learning. The strategy that I'm presenting here is one by a Professor Leitner, which was in the early 70s, a German professor who developed a strategy based on these forgetting curves, where a series of, again, information would be boxed into certain spaces using flashcards that we've probably all used here at some point of time. And if a piece of information on the flashcard was recalled after 2 days, it was then put into a further box to recall after 4 days. If it was forgotten, that information was repeated again as information learned on the first day. So it was the information that you can recall over a longer period of time. You are forcing yourself to recall over even a longer period of time, and so on and so on. And if over a longer period of time you are no longer able to recall it, you start all the way from the beginning. And so essentially he identified that the best time to relearn something, and we've seen this right before, I mean, forgetting curves, yeah? The best time to relearn within a forgetting curve is just before you're about to forget it. And he also observed that forgetting curves are variable for different information. And as hard as you try when memorizing information, certain memories will stick and certain memories won't. And the way that you can deal with this is by sorting them in cards and sorting them in flashcards, and using those flashcards in a system that mimics your forgetting curves and still allows you to recall that information exactly when you are most likely to forget it. So we're spacing repetition, we're repeating, and we're doing repeating based at the time when we need it for the information that we're about to forget. And just for an example, what you have to face, this is a board question from American board exams that I'm sure some of you have also taken. Some of the attendees have taken or may still take in some form. There's long questions where you're presented with patients with palpitations, no further symptoms, significant for Wolff-Parkinson-White, supraventricular tachycardia, alcohol history on the previous night, regular blood pressure with atrial fibrillation at the same time. And I've just highlighted some of the most important aspects on this question, but you can see that in one question, there's actually quite a lot of information that you have to put together and sort of recall in different ways. What type of side effects, what type of treatments, what type of diagnostics. And this is an example of many questions that you'll have throughout medical school, and just an example of one small part of the information that you might have. And the way these cards would then work, or this information, or let's say learning system might work, is that you take some information that you find here. So we've learned that stable Wolff-Parkinson-White patients can be rhythm controlled with cardioversion, or you can use medication, procainamide in this case. And we can also see, okay, it's caused by an accessory nerve bundle in the heart. We can use all the information we've learned from this one question, for example, or from information that we've just learned, and organize that into flashcards. Flashcards might look something like this, where we say, okay, what is the likely diagnosis when we have an ECG pattern, like we've seen here? What do we do when we have instability in terms of atrial fibrillation, if it's unstable, if it's stable, and so on and so on. As you can see cards here. Then we might have an answer, making flashcards for ourselves with information, with little details on them. And further, we would then be able to use this system. So the best sort of thing which would happen right now is that we then are able to copy the systems and learning system, like the learning processes I've just talked about. Thankfully, we don't have to do this ourselves anymore. We don't have to write actual cards anymore. All we have to do is plug this information into commonly available applications that are not only free, but also available and also attached to larger databases. In the case of medical school, what many students have started using over the past 10 years, if not longer, has been a program called Anki. Anki is a free program. It exactly mimics the ideas talked about right now, with the Leitner system, where we're memorizing and recalling information exactly at the point we're going to forget it. This information is organized for us automatically. Not only that, the user and databases that are available with this program are free, and they're open source, so that many contributors are there. That means in specific medical school now, you can have a lot of resources that are freely available that tell you exactly the information that you might need for the next exam, but also for the medical world, as well as, of course, other sciences. In the medical world, there are many resources for young doctors, for people interested about a specific topic in medicine, or interested about microbiology and looking to refresh their knowledge, where it's basically a plug and play process at this point. Of course, all of us are aware of cards and applications like this from Duolingo or Babbel that also are commonly advertised at all. It's just good to know that there is a science behind this, and there is a thought process behind why these applications work. And knowing that these applications lead to success and lead to actual learning is enough to motivate a lot of people to eventually start doing this. And that's what happened in my medical school, where people have started using these apps because they see that it makes sense to use them, because they end up working. And we're talking about simple user interfaces where all you have to do is click, you have a flashcard, it's integrated into some additional information, and the repeating and the intervals and the time intervals are set up for you. So you can have thousands of flashcards, and the time intervals, everything else will be organized for you. Here we have some further. I have backup slides in case the animations didn't work in this case. So getting to conclusions. What I want to say with this presentation is learning can be learned. And knowing how learning works and how memorization works is an important first step. But the other great thing is that using all the technology we have today, all these processes can be automated. So we know how learning works, we know how efficient learning works. And at this point, we have plug and play processes and plug and play programs that just work. You just have to click a button and start using them, and they will work and they will lead to success. And in the idea of medicine, or in the idea of any sort of field where you have to memorize a lot of information, I think knowing that there are things out there that once you start using them and once you take the time to learn how to use them is very exciting. And whether it's for the short term or the long term, these resources are very valuable, and at the same time, they are very easy to access and only require a small amount of effort from the user, which is you. And thank you very much. If there's any questions, of course, they will be asked at the end. So thank you very much.
Thank you very much, Karim. Very interesting, actually. Learning is a process, can be learned. That's right. We will discuss with you at the end, hopefully. I guess there is a multiple question regarding this topic. Next speaker, it is a pleasure to introduce Dr. Gul Dadlani. Dr. Gul Dadlani is a chief of pediatric cardiology at numerous children's hospital. He is currently serving as a pediatric cardiologist at Johns Hopkins All Children's Hospital Heart Institute in St. Petersburg, Florida. Dr. Dadlani, special interest in pulmonary hypertension, congenital heart disease, heart failure, and Williams syndrome. Today, he will present pulmonary hypertension and congenital heart disease. Most welcome, Dr. Dadlani, and speaker for you. Thank you.
Well, thank you for the kind introduction. I appreciate the opportunity to speak here today with all of the esteemed faculty members. The topic that was asked was pulmonary hypertension and congenital heart disease. And I added why are children different than adults with pulmonary hypertension? So I hope in the next 15 minutes, I can give you a quick overview of pulmonary hypertension and explain to you why children are different and why the approach that you take in the cath lab with these patients is so vitally important for their long-term well-being. I have no disclosures for the lecture. For our objectives for the next 15 minutes, we're going to look at the etiologies of pulmonary hypertension, our normal fetal heart and lung development, common symptoms, and then medication therapies for pulmonary hypertension. Now, when we look at the heart system, when we look at our heart and lung in terms of a flow model, we know that the right side of our heart pumps blood to our lung bed. We pick up oxygen in the lung bed, and then that gets returned back to the left side of the heart. So when we look at etiologies of pulmonary hypertension, we have to look all the way through the circuit. So we can have issues in terms of left heart failure that can cause backup into the lungs. We can have issues with our pulmonary veins returning back to the left side of the heart. We can have primary lung-related issues, or we can have pulmonary artery issues that can all elevate our right-sided pressures as we detect those on our cardiac catheterization. So when we look at the role of a pediatric interventional cardiologist in pulmonary hypertension, I think there's a couple primary roles that interventionalists play in the management of pulmonary hypertension patients, and all of these are crucial to their long-term well-being for each patient. Number one goal every time you take a patient to the cath lab is there any mechanical obstruction in that circuit that we just talked about that needs to be addressed, either through ballooning, stenting, or others with that. Number two is how can we give an accurate hemodynamic assessment that can then guide our medical therapy to either add medications or enhance our medical therapy from baseline if there's progression of disease. Number three, I would hope that all of you would be an advocate for early and aggressive medical therapy. And number four, the cardiac cath that you do is vitally important to discuss with your surgical team so that you can plan accordingly safe and effective surgeries for every single patient with congenital heart disease and pulmonary hypertension. So when we look at the lung makeup of someone with pulmonary hypertension, this is an MRI image looking at pulmonary hypertension. You can see the main pulmonary arteries are dilated. The branch pulmonary arteries are very small and limited arborization of those pulmonary arteries with that, which is commonly what we see as those pulmonary arteries thicken. We lose the arborization pattern with that. In the cath lab, you will have different scenarios that you come across. This is an MRI 3D image of focal pulmonary vein stenosis that Dr. Ebid cast and put a nice stent into. So we appreciate that. You can also have pulmonary artery stenosis where you have stents laid into the pulmonary arteries. Or you can have parenchymal disease. This is a premature child with chronic lung disease that has pulmonary hypertension as well. So. In either of all of those cases, the definition of pulmonary hypertension that we're going to use is a mean pulmonary artery pressure greater than 20 millimeters of mercury with a wedge pressure of less than 15 to rule out left heart disease and a pulmonary vascular resistance greater than 3 Woods units. When we look at our World Health Association organization classification of pulmonary hypertension, it breaks us into 5 major categories. Number 1 is pulmonary artery hypertension. In here are your idiopathic forms of pulmonary hypertension, such as genetic disorders. Number 2, also in there are patients who have congenital heart disease. Our second category are patients who have left heart disease, so those with cardiomyopathies, heart failure in that group. Number 3 is patients who have developmental abnormalities of the lung, so this will be our premature infants with that. Group number 4 is our thromboembolic disease, and number 5 is patients who have multifactorial disease, such as connective tissue processes, sarcoid, and those processes, which are much rarer in children with that. So when we look at those 5 categories, anytime we're facing a new patient, we want to be able to categorize them to ensure that their workup is effective. Now, if we focus on patients with congenital heart disease and pulmonary hypertension that were in that first group of pulmonary artery hypertension, the lesions that most commonly are associated with pulmonary hypertension will be those that have transposition, tetralogy, truncus, total anomalous pulmonary venous return, or partial anomalous pulmonary venous return, as we've just heard great lectures about, and our single ventricle population with that. These patients are at risk of pulmonary hypertension because they have an increased QP to QS or increased flow to the lung. They may also have abnormal growth and development of their pulmonary arteries, depending on if they have associated genetic disorders, such as DeGeorge or Alagille's or other genetic syndromes. They may also have had multiple surgeries to the pulmonary arteries or compression of the pulmonary arteries in terms of the single ventricle population, as the Norwood patch may push down on those pulmonary arteries with it. They may also have abnormal pulmonary venous growth and diastolic heart failure as well. So when we look at those mechanisms of pulmonary hypertension, those patients that have increased QP to QS and higher oxygen levels within the pulmonary circuit may also undergo changes within their pulmonary vasculature, where the expression of nitric oxide synthetase decreases due to high oxygen levels, so that after surgery, if you are repairing someone that had a large VSD and all of a sudden take away that shunt, you may get reflexive pulmonary hypertension just due to downregulation of the nitric oxide pathway with that. So the biggest question that comes across to interventionalists from their surgery team anytime they're taking someone with congenital heart disease and pulmonary hypertension to the cath lab is, can we safely operate on this patient after the cath? And I think you want to go stepwise in terms of looking at your patients and really look at them as a whole. to really understand and ensure their safety as they go for cardiac surgery. So number one, we want to look at the age of our patient. We know that patients that have had unrestricted pulmonary blood flow for over 2 years may develop irreversible pulmonary hypertension. We also want to look at the complexity of the heart lesion that we're dealing with. So truncus arteriosus has unlimited pulmonary blood flow because there's no valve going to that flow going to the lungs. So you get inundated with excessive amounts of pulmonary blood flow. Unrepaired transposition would be similar. And patients with Down syndrome can also develop pulmonary hypertension as well, just due to pulmonary arborization abnormalities associated with Down syndrome with that. Next is also, do they have congestive heart failure? It's always reassuring, actually, if you see signs of congestive heart failure in that population, because that tells you that there's still extra flow going to the lungs and that they haven't developed irreversible pulmonary hypertension yet with that. And when we go to the cath lab, we want to be able to challenge those patients with oxygen and nitric oxide to test the pulmonary vasculature and look at that pulmonary vascular resistance as well with that, to look for those changes with it. This is just a nice little flow chart that you can use in your clinical practice when you're assessing a child with pulmonary hypertension. So we do that preoperative assessment so that we can avoid having mortality with pulmonary hypertension when we have a child with congenital heart disease and pulmonary hypertension. When we look at the cumulative survival of children with pulmonary hypertension, this study came out of a multi-center study and looked at overall life expectancy and survival. And you can see that survival is about 80% as you look out past 7 years with pulmonary hypertension in pediatric patients. Again, our adult counterparts would have worse outcomes with that. In addition, at pediatric hospitals, if you look at in-hospital cardiac arrests, approximately 35% of children at large institutions may have some level of pulmonary hypertension prior to their arrest. So it does put you in a high-risk category if you're admitting a patient with pulmonary hypertension for preoperative surgical assessment or post-cath assessment. So these are some of the highest risk patients in any pediatric hospital and do have a substantial risk of a sudden cardiac arrest in this group. This was data out of Children's Hospital of Philadelphia. So I think in order to really understand pulmonary hypertension well, we have to understand the embryology and the development of our heart and our lungs in collaboration together. So we know that our heart is fully formed by the 8th week of gestation, and our heart tube grows separate from the lungs. Our lungs will develop separate, and our pulmonary veins will grow back to the left atrium and meet the left atrium and then have disintegration of the membrane between. We saw the great presentation of the Cortria atriatum that has lack of disintegration of that membrane there from a partial standpoint, or total anomalous pulmonary venous return if the membrane were to stay in completeness. When we look at the lung development, it is different than the heart. So the heart is done by 8 weeks of gestation here. The lung continues to develop over the whole gestation, all 40 weeks, and even after gestation with that. So you can look at the different levels of development of the lung over the 40 weeks of gestation. You can see that the alveolar or small airway development doesn't occur until about 36 weeks of gestation with that, prior to delivery. And surfactant production doesn't start until after the 24th week of gestation. So as we look at premature babies and things like that, there are new models coming out of trying to save premature babies with artificial placentas that may give us benefit to be able to push this limit less than 24 weeks in the future. But if we're counting on babies coming out and surviving on their own, to try to push this less than 24 weeks, it becomes very difficult without adequate surfactant production. When we look at the development that occurs after birth, when babies are born, they're only born with about 1/3 of their alveoli. The other 2/3 of the alveoli grow classically between birth and age 7 and 8. So by 8 years of gestation, the lung is fully developed. We know that new models of lung development have been studied, and that stem cells and ability for the lung to regenerate is there in comparison to the heart. So if you have a significant lung injury, let's say from COVID or other, there is possibility that the lung can continue to remodel even after age 8, that it's not fully done with all of its potential growth with that. And as we look at those levels of development in the lung after age 7, we can break down our lung as we study it from a cath standpoint. As we do our heart catheterizations, we're looking at our main pulmonary artery, our branch pulmonary arteries, and then all the segments within the lung. So whenever you take a child to the cath lab, we want to ensure that we have full assessment of both sides of the heart, of the lung with that. Now, when babies are born, they go through a large transition, and we know we have a very sudden drop in pulmonary vascular resistance and our pulmonary artery pressure after birth. So typically within 24 hours after birth, the pulmonary vascular resistance is dropped by about 50%, but does not drop to full adult levels until 6 to 8 weeks after gestation. So heart failure can continue to progress during that time. With that, these transitions are delayed in premature babies. And again, the need for medical intervention while the kids are going through these transitions can help dissipate the degree of pulmonary hypertension and improve survival during these times. When we look at the ability of pediatric patients to recuperate in comparison to adults, the Netherlands have a national database of all patients with pulmonary hypertension. This is a study from 2011 in the Netherlands that looked at all pediatric pulmonary hypertension patients. You can see that those in yellow had lung disease, those that are in red had left heart disease, those in green had progressive disease. So this would be the genetic portion there. But this, about 2/3 of the patient had this transient pulmonary hypertension that improved due to either developmental issues or prematurity in the lung bed. So there is ample opportunity for progressive growth of the lung bed over time, as long as we support the lung while it is growing. We know from a pathology standpoint, what we want to avoid is progressive smooth muscle thickening and scarring within our pulmonary arteries. These are examples of pulmonary arteries that have undergone hyperplasia of the smooth muscle within the small vessel walls and or complete occlusion of the vessels over time. When we look at the clinical features that thickening can cause in those pulmonary arteries for children, syncope is one of the largest symptoms that we worry about in 31% of children. Dyspnea, especially with exertion, is also a common finding as children continue to age with that. For those with associated congenital heart disease, they will have less syncope if they have an intracardiac shunt, because as they clamp down their pulmonary vasculature, they're able to shunt across and still maintain a systemic output during those times. Also, patients with trisomy 21 may have excessive symptoms as well with that. The World Health Organization has classifications for pulmonary hypertension, class 1, 2, 3, and 4, similar to the New York heart failure symptoms for that. There are also age-related classification for pulmonary hypertension symptoms that one can look at. And the reference is here on the bottom for you. They break down the classification by age, less than 6 months, between 6 months and a year, 1 to 2, 2 to 5, and then 5 to 16 with that. Now, as clinicians, as we evaluate patients with pulmonary hypertension, we have to look at the whole patient. So this is a nice checklist when you are evaluating patients to kind of determine their risk and their overall assessment with that. So for every patient you come across, do they have exercise related symptoms that have progressed? Have they had syncope? Have they had any failure to thrive related issues? And then what are their World Health Association symptoms? And have they had any elevation of their BNP? over time with that. So those are just, this is a nice checklist that you can keep for your patients with that. So once we have that assessment, then we can look at our medical therapy for those patients. And when we look at that, there are flow diagrams that we can look at to assess when to start medical therapy on these patients and when we should add extra therapy for these patients. The easiest way to kind of look at our medical options for patients with pulmonary hypertension are, number one, start oxygen on these patients. So even if they're older patients, I usually use oxygen at night to try to help relax the pulmonary bed. And then we have options for medical therapy. So there are three major pathways in the heart. Number one is our nitric oxide pathway, which will be your sildenafil or tadalafil that block the phosphodiesterase 5 inhibitors with that. You can also use endothelin. Endothelin is a protein in the heart muscle, or sorry, in the lung bed that cause hyperplasia of the smooth muscle. By blocking endothelin, you're able to slow the progression and also the functional ability of the pulmonary vasculature with that. Our third class is our prostacyclin pathway. Prostacyclins, whether you're using epoprostenol or treprostinil, they act very efficiently. They were typically given as IV derivatives. They're now available inhaled and even in oral versions in some parts of the world with that. When we look at safety with that, sildenafil is the most commonly used medication for pulmonary hypertension in children and has a very good tolerance in this age group. As you look at the survival curve with that, patients who use low-dose sildenafil, it's safe, it's well tolerated, and their longevity is improved by using it. This is data out of Columbia Children's Hospital in New York City. In addition, bosentan is an endothelin receptor antagonist and blocks production of endothelin and will help to, again, decrease smooth muscle proliferation within the pulmonary vasculature. It has been shown to be helpful even in patients with Eisenmengers who have fixed related pulmonary hypertension to improve their quality of life in addition to their clinical symptoms with that, and also increase their exercise capacity. Our third class is our prostacyclin pathway, and our prostacyclin group are typically reserved for patients with severe pulmonary hypertension or have been refractory to the other two classes. This can be used in the acute setting for persistent pulmonary hypertension of the newborn. It can be used for postoperative pulmonary hypertension as well after cardiac surgery with that, or after diaphragmatic surgery. This is a case that we did at my institution, looking at intravenous treprostinil in the utilization of persistent pulmonary hypertension of the newborn. And again, we were able to wean that child off within 40 days with that and really be able to save their life by utilizing that. Today, you can also utilize the prostacyclin family as inhaled agents acutely as well. So you don't have to use them IV. There is possibilities of giving them through a ventilator setup along with nitric oxide as well, depending on your institution. The other thing that I want to impress upon you is the need for consideration for combination therapy. Using sildenafil or tadalafil in combination with an endothelin receptor antagonist has been very beneficial for many patients with pulmonary hypertension. And the sooner you add dual therapy to them, the better their pulmonary hypertension tends to get. This is a look at patients who are followed out 6 years, and dual therapy outperforms monotherapy in terms of overall cumulative survival, and has also shown improved clinical symptoms as well in terms of their exercise capacity when you compare combination therapy to dual therapy with it. So in summary, I hope that we touch base on the importance that interventional cardiologists play in the evaluation and assessment of patients with pulmonary hypertension with and without congenital heart disease. I would encourage you always to ensure that any heart cath done removes any mechanical obstruction within the cardiopulmonary circuit, and that you push for early therapy and combination therapy to enhance remodeling and improve survival over time. And remember that the lung has potential to grow and develop. So as children are growing, they have the opportunity in some cases to outgrow their pulmonary hypertension. So please do your best to continue to give every child every possibility as they come across in your clinical practice. So again, I appreciate the opportunity to speak here today.
Thank you very much, Dr. Dadlani. This is very elegant and interesting topic and very elegant presentation. Thank you for joining us. Thank you for your presentation.
You're welcome.
Now, before we go for the discussion, I'd like, on behalf of the organizing committee, I would like to thank all the speakers for their outstanding and elegant presentation. Also, I would like to thank the sponsor for this webinar, Jensen & Jensen. Without their support, this webinar could not be happening. Thank you very much. And I will leave the speaker or the mic to Dr. May for leading the discussion. Most welcome.
I would like to thank you all for the elegant presentations, and we've got a few questions for you all. First of all, we have some questions about the diagnosis of total anomalous hemodynamics to Dr. Alaa. Somebody asked about the whale sign in the supracardiac coronary sinus type and how to differentiate mitral ring. Alaa. Dr. Alaa around?
Yes, I'm here, Dr. Maya. I just answered in the Q&A concerning the whale sign. The nomenclature means that there is an abnormality or the connecting veins drain directly to the coronary sinus, giving it a picture resembling the tail of a whale. So this is a descriptive sign or describing the morphology of how the pulmonary venous connection to the coronary sinus, giving the picture of a tail of a whale, just to describe the morphology of this connection.
And the differentiation between the chordoatriatum and supramitral ring?
As regards the supramitral ring is more or less similar to, if we can describe it, would be similar, very close similarity to the subaortic membrane. It is a very close membrane to the mitral valve itself. So it does not separate the left atrium into two chambers. It just separates the mitral valve from the entire left atrium. It can be part of a differential diagnosis of a chordoatriatum from the physiologic point of view, because both of them will have a picture resembling mitral stenosis if they are tight enough or restrictive enough to cause obstruction to the left ventricular inflow. But from the morphologic point of view, the supramitral membrane is a membrane very close to the mitral valve. And unlike the chordoatriatum, which is classically dividing the left atrium into two parts and extending from the pulmonary vein ridge to the opposite side of the interatrial septum.
And I guess the next
something.
Yes, please.
The differentiation. Some people think that the chordoatriatum is above the left atrial appendage, while the membrane of the mitral valve is below the left atrial appendage.
Yeah, and I agree.
This is how, like, the best way to differentiate them. Otherwise, I agree with Dr. Alex. Sometimes you can mix them up, but if you look at the left atrial appendage, you can differentiate it very well.
Yeah, I agree. The next question actually goes to Dr. Zahir and Dr. Ashraf. So, what about the cath palliations? Jamil, Zahir, can you elaborate on that? in the case of obstructive total anomalous pulmonary venous drainage? And for Dr. Ashraf, do you think this is will be helpful preoperatively, or would you rather go and do this during the operation?
Is Dr. Zahir around, or Dr. Omar? Maybe you can comment on that.
Can you comment on that, Dr. Omar? Dr. Ashraf?
Yes, yes, Dr. Mai. I think the cath, according to the literature and according to the practice, the rule in the septostomy for those patients to enlarge the ASD is not helpful enough, and always delay the surgery. The same is to go to the surgery in the first place as an emergency is much better and much better results than go to the septostomy, which is usually not enough to relieve the obstruction, and also is not a good relief for those patients for the drainage of the pulmonary veins. Usually is to go to the surgery to enlarge the ASD, to reroute the veins and enlarge the left atrium is much better results without delay for surgery, according also to the literatures all over the world.
What about, Dr. Halak has suggested putting a stent in at the obstruction. Do you think this would be helpful in making the results, surgical results better? To relieve the obstruction first?
If the obstruction is not on the level of the atrial level, maybe a cath has a role for stenting of stenosis on the ostia of the pulmonary vein or inside the pulmonary vein, yes. But in the atrial level, the atrial level is much.
I mean, would this make the surgery, surgical results better if you just go ahead and stent the obstruction and then go to surgery following that?
Can I comment on that?
Of course.
Actually, the intervention has a rule, but it is a selected patient. First, selection in regards to the sickness of the baby. Some babies that are very, very sick, so they cannot tolerate to go for a bypass surgery immediately. So the palliation with the, as you said, with the stent, it is optional, but the possibility to stent, it depends where's the obstruction and if you can reach it by a catheter or not. On the other side, we have to keep in mind if they are obstructive pulmonary vein, this baby are very sick. So even the intervention carry a high mortality or high risk. Third point, if we're going to stent, it happened to us, better to put a stent and enlarge it as much as you can so it fit in the vein. Otherwise, it will not stay in the place.
Yeah, I
and
agree.
the day after, it may migrate and move somewhere else.
I agree.
Can I?
Yes, please, Helen.
My suggestion is, as you know, all the neonates or the infants are very ill. They are very cyanotic. They are very poorly doing. So putting a stent is a palliation to put them in a good shape before surgery. And putting a stent, as long as you said it's a coronary stent or value stent, to relieve the obstructions, raise the saturations, decrease the pulmonary edema, and get them to the operating theater in a good shape. So if the operation is accessible, either it is ascending vertical vein or even in the lower down below the diaphragm, you can access them from the systemic veins. It's a better solution and it has been reported. Thank you.
No, but the obstruction sometimes either in the ductus venosus, then you have to act very quickly because when ductus venosus is closed.
Yes.
And the other thing, if they drain to the portal vein, you cannot access them.
Yeah.
Yes, yes, it is multi-invalid.
So we agree it is optional in selected places.
Yes.
Yes.
Yeah, okay. So some questions, a lot of questions for Scimitar syndrome, but Dr. Zahir has left us apparently, but maybe we can all discuss that.
Can you hear me?
Dr. Zahir, are you there?
Now we hear him.
Okay. My mic was playing with. Okay.
Okay, so there are questions regarding what age do you suspect pulmonary hypertension in partial anomalous pulmonary venous drainage? Do you think this would happen soon, late, the adult age, in the adolescence?
I think we have to assume it as like an ASD. So if it's a single pulmonary vein which is anomalous, you are highly unlikely to develop pulmonary hypertension. So usually pulmonary hypertension will develop if whole of the right or left lung is draining and it gets undetected, and usually it should present in adult life as you would expect it with an ASD. So it depends on how significant is the shunt. If QPQS is high, usually they will present in their 30s and 40s. And as I showed one of the case, that it presented in the third decade of life. So I would not have expected them to present earlier than that.
But if you diagnose them early, when you will treat them?
Yes. So again, I think the best way to you don't have to do them early in the life. You can leave them. You can do an MRI, you can do cardiac catheterization, want to check their QPQS, and if an indication is there, what they have described is that usually the results are better if you leave, for example, say 10, 12 years of life. Then if you do the rerouting, that has much better results than doing it less than 5 years of age.
I have a patient who is in her 30s and she just discovered she had Scimitar syndrome. She went through pregnancy, she's fine, asymptomatic. Do you think anything should be done about her or just leave her alone?
Yes.
Very, very good question. Again, if she's doing well, you can always leave her alone, but you can always do, the problem is going to be if she has significant shunt and if she gets left untreated in her 4th or 5th decade of life, then she might end up in trouble. So again, you probably will have to think about doing an MRI, do a QPQS estimation, and then based on that, you can make up that decision. But it's not an easy decision if somebody is doing very well and we expose them.
She went through pregnancy, she delivered, she's fine, no pulmonary hypertension, no symptoms.
Yeah, there's always an option of watchful observation in these kind of patients.
Doing that in this patient.
Could I comment on this, if you allow me?
Yes, Khaled.
I think the shunt, I mean, when we talk about ASD, isolated ASD, with the pulmonary hypertension, we need to be careful not to label patient pulmonary hypertension because of ASD. I think usually we need to look to other causes, especially in younger, I mean, in 20s, 30s. Again, the anomalous veins or the sinus venosus with anomalous vein. We need to be careful before labeling them pulmonary hypertension because of only shunt. Then the other thing with regard to a 30-year-old or whatever, even if the 40-year-old who's just diagnosed to have a Scimitar or an ASD or anomalous vein, I think the guideline, the recent guideline, the European one, September 2020, is very clearly saying that any patient who had a shunt calculation more than 1.5 to 1, pulmonary vascular resistant is less than two-thirds of your systemic vascular resistant, or absolute number below 4. This could be closed straightforward. Those patients who's between 4 and 6, or even some people say 4 and 8, you could treat a repair. So you could do a hemodynamic, very careful, then get them some pulmonary vasodilator, then recat them again. But I think leaving someone with a shunt, with a normal pulmonary vascular resistant and normal pulmonary artery pressure, I'm not sure it is the, even if he's asymptomatic. You know, all of us, that patient who come in their 30s, most of them with ASD or anomalous vein, they are incidentally discovered. They are, I mean, usually, I mean, this is different than the late ages, like 40s, 50s. In the guideline, it's very clear that saying, once it is isolated atrial shunt, is that you need really to, if it is closable, deviceable, this is easy. If it is surgical, you need to weigh the benefit against risk. So someone who had a multiple, comorbidity with an anomalous vein, asymptomatic, even if it is there, I might not do anything because those usually have other comorbidities. So this is, I think, for adult here.
Yeah, but because Scimitar surgery is not like ASD surgery. I mean, it carries risks, it carries post-operative complications of obstructions and everything. So that's why it's a bit different from ASDF. That's my thinking.
Yeah, but
Other
it's
questions regarding closing the collateral, Dr. Zahir, is it, some people would say, if it's only blood supply to the lung, what happens next? And it's because it's systemic supply only. Can we close it then? And if we close it, shall we close it or not? And what would be the next step? And what would be the indications of lobectomy in a Scimitar? Is that question from the audience?
So this aortopulmonary collateral, that's not only blood supply to the right lung. That's an additional.
They're saying if it is the only blood supply, would you still close it? For the specific flow?
I never saw something like this.
I still, I mean, I don't understand that. How can that just be the only blood supply to that lung? Usually
to the lobe, they mean.
Yeah, that's the lobe. Yeah, and usually it's a sequestered lung lobe, and usually you need to get rid of that sequestration anyway. So so the benefit of closing is there. There's no, if you leave it, that's a nidus for infection, recurrent infections, bronchiectasis, and that's coming to the indication for lobectomy. Probably that's going to be an indication for lobectomy if this persistent blood supply is there, and that acts as a nidus for a long-term problem, especially bronchiectasis. So yeah, so I think whenever you see an AP collateral, you should not you should not hesitate to close it. You should just close it.
Our policy too.
Comment, May?
Yes, please, Dr. Millet.
I think the AP collateral in either sequestrated lung or in Scimitar usually, the AP collateral, it is adding more risk and more hemodynamic sequelae than supplying the lung parenchyma. The old thinking is during 80s and before, they are thinking if you close this collateral, the lung may go in necrosis. But it show up by time, it is not the case. If you close the collateral, the baby get benefit from the bad hemodynamic effect.
And I think Dr. Zahir has shown us one case where the right side has improved in size and the pulmonary pressure.
And the lung parenchyma is supplied by intercostal arteries, so it has nothing to do with the lung parenchyma supply. This collateral usually it is as adding circulation around the alveoli and drain to the right side of the heart.
I hope this has answered the questions of the audience who asked about the AP collaterals. The rest of the questions are really about pulmonary hypertension. I have a question, Dr. Gal. Dr. Gul, what is your policy in the neonatal period for pulmonary hypertension? I mean, what do you start giving sildenafil straight away? Do you start by oxygen ventilation, or do you start by medication to support the lungs in cases of neonatal pulmonary hypertension?
Sure. For neonates, I think when you look at a neonate with pulmonary hypertension, you want to do a couple things. One, you got to ensure you have adequate ventilation for that child with removal of carbon dioxide for that. Number two, we use oxygen therapy on those children. And number three, you got to ensure that there's no reflux. So chronic reflux can be missed in premature babies, and you have to exclude chronic ongoing reflux, with that. Once you have those, what we've looked at is screening neonates, between that 24 to 27 week period. If you have those children on oxygen more than 30 days, they would clearly benefit then from adding a pulmonary vasodilator on board. In our institution, sildenafil. If you're premature, if you're older, you can use tadalafil for once a day dosing. Before we ever do that, though, we always want to make sure that there's no significant intracardiac shunt. So if there is a PDA, that we get that PDA closed and out of the picture, because obviously as you add pulmonary vasodilator therapy on top of a significant intracardiac shunt, you'll only increase the amount of pulmonary blood flow with that. So we are always, fully assess the each child for a PDA prior.
The reason I'm asking that because for the audience, we see a lot of practice of putting sildenafil straight away when you have a patient born with pulmonary hypertension or has a duct or still a PFO, and still the pulmonary artery pressure on the first and second day is still high, and some neonatologists would just straight away go and put sildenafil in. I don't think this is going to be very beneficial. So you say don't start this before 30 days of giving adequate ventilation and
We
oxygenation.
don't usually
right?
know.
Yeah, okay.
So if they're stuck on nitric, for oxygen and nitric oxide, we have inhaled nitric as well. So if we are stuck on inhaled nitric and can't get off, then we would do it earlier than 30 days. But
Right.
for the most part, we try to wait if we possibly can.
Okay.
But-
Because it will be more deleterious than beneficial then, correct?
But if you have an open duct, yes.
Okay. And other questions about the diagnosis of pulmonary hypertension by echo. All the diagnosis there is only the numbers by cath. So somebody's asking about what is the levels at which you would diagnose pulmonary hypertension by echo. What are the numbers? Because they're
sure.
usually a little bit higher than the cath.
Yes, so if you have a TR jet of 40, you're going to have, elevated RV pressures with that. I think you have to take their gestational age into accommodation with that. So do they have, again, if it's a premature baby and you have an open duct that is artificially elevating your RV pressure, again, you got to get the duct out of there from a medical standpoint or a surgical standpoint first on those children. If you look at older children, those with sickle cell, those with other underlying lung disease, then if you have RV pressures by echo consistently over 40, implementing medical therapy on those usually will be beneficial. And if you take those children to the lab, their mean pressure then is typically 20 or above.
Okay.
Can I ask a question, please?
Yes, please.
Actually, when we talk about pulmonary hypertension, it is a destination. So I think we have to be careful if we are talking about pulmonary hypertension in normal anatomical heart, which is the best pulmonary hypertension, or pulmonary hypertension with congenital heart disease. Many patients with congenital heart disease, they may have pulmonary hypertension, pulmonary vascular occlusive disease, and they don't have TR because they vent through the defect somewhere. I mean, either BDA or BSD or somewhere else. So it is a little bit crucial when you think about the echo and diagnosis of pulmonary hypertension. So that's the comment. My question to Dr. Dadlani, all of us, we say, when we talk about operability of pulmonary hypertension with the shunt, so the pulmonary vascular resistance, if it is less than 4 or 5, some people say it is operable. Between 5 and 8, it is gray zone. You have to test, and over 8, it is. The problem, how to get these numbers? When you measure pulmonary vascular resistance in presence of shunt, actually, the calculation of cardiac output, and even if you test with vasodilator medication, there's a lot of dilemma, a lot of assumption in that equation to calculate the pulmonary blood flow and then calculate the resistance. So what's your comment about this issue, please?
Sure. Again, depending on the age of the child, if you have a significant shunt, again, if you're in the lab and you can calculate, the direction of that shunt, or by echo can assess the direction of that shunt. If you have left to right shunting, I would always be an advocate for taking it out independent of the calculation of your, resistance on that. Because if you have an opportunity on a growing child to limit the pulmonary blood flow, I think that's the best option for those children. Obviously, if they develop irreversible Eisenmengers, then they would be cyanotic all the time with that, and have right to left shunting with that. But if you have intracardiac shunts that are left to right, I would really push for trying to get as many of those out as possible. So if you can close them in the cath lab, that is beneficial to limit their pulmonary blood flow and try to return them to normal circulation with that. If you're closing an ASD or a VSD, you can always test occlude it and then do a SAT run after closure as well to reassess. We've closed patients with significant size ASDs with elevated resistance and left them on medical therapy with sildenafil or dual therapy with sildenafil and bosentan, and you know, within 1 to 2 years, then taking them off, and had success as well with that. So.
Yeah, I think this answers the.
Any comment about MRI cath? I mean, to calculate cardiac output with MRI and cath with a blood
Yeah,
pressure.
MRI is a great modality depending on your institutional access for that. Obviously, you can calculate QP to QSs on MRI. We have utilized that, as you can see on the pictures we showed. You know, those were MRI 3D recreations with that. So MRI is beneficial for us in terms of assessing the QP to QS. If you have multiple intracardiac shunts, it becomes a little challenging, but it does give you the overall QP to QS.
I think what you said right now is an answer to a question here that asked about the approach to medical management of the pulmonary hypertension, because there are lots of questions about whether you should do that preoperatively, example for patients with the AV septal defects and Down syndrome, postoperatively. How do you use that? I mean, do you keep them and then restudy them after a while? You've just said in a year or two, they might be operable. So do you have any further comment on that?
Sure. If they're an appropriate age, you know, if you're under 2 and you have left to right shunting, we don't preoperatively cath all of our Down syndrome patients. We'll repair the defect, and postoperatively, if they have elevated RV pressure by echo, then put them on short-term sildenafil. And then if they're still maintaining and needing that, then cath them a couple months later.
So you start monotherapy, not dual therapy in those cases. You don't
Start monotherapy.
Monotherapy.
Monotherapy first. Again, if not responding though, then we would go to dual therapy.
Yeah.
Within a couple months.
So you keep them a couple of months on sildenafil, and then not responding, move on to dual therapy, and then recath.
And many respond right away, so that you
Yeah.
know that you don't even have to. You can wean it off, and they do okay. But you know, the non-responders obviously.
Do you keep them for a longer period? I mean, once they are better, I mean, do you still keep them, especially Down syndrome patients? Do you keep them on sildenafil for a longer period, postoperative?
It depends on the child. I mean, if they're going in with high pressures, and then we close an intracardiac shunt. If they come off and they're looking well, then we let them be. Obviously, if their postoperative echo still shows significant pulmonary hypertension, then leave them on for 3 to 6 months and then reassess.
Okay, great. 2 more questions about for interventions. And there's a question here doing that if after repair of total nominal venous drainage, the vertical vein is still patent, is it safe to close it by device? This is one question, I think. Does anybody care to?
Sorry,
I mean, some because I've came across a patient like this. There is a question: is after repair of total nominal venous drainage, you find that the vertical vein is still it is repaired, but the vertical vein is still patent. Would you close it by device?
So why the surgeon left the vein patent?
It just happened.
Of course, you have to close it, otherwise it will be it was a source for thrombosis or whatever is it, I don't know.
And there is a question that I don't understand, but I mean, does anyone has experience with partial anomalous venous drainage with double drainage and treated by catheter? I'm not sure.
What do you mean double drainage? Sorry.
No. Maybe, I don't know.
I think that would be a surgical option.
Yeah, I think it's a surgical option. Finally, can MRI calculate QPQS in patients with intracardiac shunts in the state of pulmonary stenosis?
Yes.
Does anybody there care to comment?
Yes, you can.
You do have pulmonary stenosis. Can you still calculate the QPQS by MRI?
I mean, MRI, you can calculate whatever you want. To the QPQS and the MPA, you can calculate the flow to the left lung and the other to the right lung. Yeah. Branch of anywhere you can calculate the MRI, the flow. So no
Finally, I would like to congratulate Karim Galal on his topic and would like to pose a question. if learning is a process that can be learned, I mean, does this apply only to medical students, or does it apply to, as you said, we have, I mean, what does it mean to people who have, I mean, we're still learning all the time. So do you think we can apply same methods at our age?
I think essentially, yeah, it's a lot of these apps that are out there for learning language, for example, work on very similar principles. And there's no reason why they can't be started. I think the nice thing about the sort of technological era we're in now is that instead of all of these processes like learning a new language or learning a new topic have stopped being an issue of where do I get all the information together, and it started being an issue of something like working out, like can I really force myself to do this for 1 hour a day? So I think, of course, I mean, I think it's definitely something for anybody. It's something in all sort of fields of study, but of course it applies most to fields of study or topics where issues have to be memorized a lot. And in areas of more understanding, for example, in medical school and physiology, stuff like this isn't so helpful, where you have to learn references to other ideas and connect ideas to one another. But anything where you have to memorize, these apps or these sort of concepts will always find themselves repeated.
I think we were all impressed by your choice of topic. We always like to put a non-medical topic in our webinars. And I think it's it lightens things up and makes it more interesting. If there is,
thank you for having me. Thank you very much.
Thank you. If there are no more comments, I would like to close the session. Thank you, all the speakers. Thank you for the discussion. Thank you, the attendees. Thank you, Jensen, for sponsoring the webinars. We'll have another webinar next month, and we're going to announce it very soon. And I'd like to congratulate all of you on a very successful meeting today. Thank you, and good night.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Appreciate the opportunity.
Yeah,
Thank you.
yeah, well done.
Good night.
Thank you, doctor. We will end the live.
Thank you.
Thank you very much.
Thank you.